reminds me of the assumptions that some clinicians can make, which is assuming that the person whose chief complaint or like, what the visit on your schedule little blurb says is contraception, right? I think sometimes we also make the assumption that this person in front of us with whatever variables they have, of course, doesn't want to get pregnant. And so
Mhm.
one of the assumptions that us as clinicians need to sort of step back on and be aware of at least is like, it's possible that the person you're meeting, again, regardless of age, might actually want to get pregnant. Maybe they want to talk about that, even though contraception is the sort of what's listed down. How do you begin your counseling about contraception or potential contraception with this assumption that sometimes happens in mind?
I think assumptions are our worst enemy, that's for sure. Um, with any conversation, I think it's really good to open with start like an open-ended question. So, are you interested in getting pregnant in the next year or so is a great opener. Or what are your thoughts about different forms of contraception? Or what have you used in the past that works for you? Or another great question is, what is the most important thing for you in terms of contraception, if that's what we're talking about today? Right? And so sometimes it's not about preventing pregnancy. There's so many non like contraceptive benefits for contraception. So, for example, abnormal uterine bleeding, menstrual cramps, headaches, migraines. There's a lot of different reasons that somebody may want contraception, and they may not pertain to preventing pregnancy. And so, really like under knowing what are the goals, and like some people can have like multiple goals, some people might have one goal, and clarifying and trying to work with that person, right? It comes down to it is like, how can we work with the person in front of us? How can we, do the shared decision making, really like work together as a team and come up with a great plan?
You bring up really excellent points because I do think that's a common misconception of these medications are for birth control, period, full stop. And that is just not the case. And oftentimes that could be one of the goals, but like you said, there often are multiple goals for folks. And that reminds me of another misconception, which is related to menstrual suppression. So some people just may not want to get a period, right? It's not working for them. It's cramping their style. They're missing school or they're missing work or for no specific reason. They just don't want one. And that comes up in my line of work too, because parents often are like, well, it can't be good or healthy or safe to not have a period. What do you think, doctor? And
Mhm.
what would your response to that be?
I would say if you are not taking medications to prevent bleeding, you are correct. It is it is not healthy to not have a period. But if we were to purposely suppress the periods, then it is normal and safe. The reason being is that when we're taking the medications to stop bleeding, it actually thins out the lining of the uterus, and therefore, of course, you're not going to have bleeding. We don't have, as species, as all many different animal species, have a period every single time. It does not mean that not having a period would increase the risk of cancer, increase the risk of being sick. That is not the case at all. So once somebody is, we quote unquote call menstrually suppressed, it is safe to continue to be that way for the foreseeable future.